Assalamu alaikum warahmatullahi wabarakatuh. Dear students, how are you? Hope you are all well and your families are also safe. Bismillahirrahmanirrahim. Today, our topic of discussion is fibroid uterus. The learning objectives of today's talk is to describe the common benign tumor that affect the uterus according to the site of the origin. To understand the presenting symptoms and examination findings associated with the fibroids. To describe the common tests used to evaluate the uterus and the endometrial cavity, and to explain the available treatment options for this benign tumor. What is a fibroid? It is actually a benign tumor which is arising from the smooth muscular layer of the uterus. You already know that the uterus has the uterine wall is composed of endometrium, the central layer is myometrium, and the outer layer is the perimetrium. So this benign tumor, it arises from the myometrium and accompanying the connective tissue of the uterus. So fibroid is chiefly composed of smooth muscle fibers and a smaller amount of connective tissue. It is also called myoma or leiomyoma. So it is also synonymous with myoma or leiomyoma. So you should not confuse. It has three names: fibroid, myoma, or leiomyoma. Regarding its pathology, grossly, it is a nodular structure. You can see it is like a globular, rounded, firm masses. Oval or rounded shaped and firm in consistency, hard, they are hard. Whorled appearance on cut section. When you do a cut section like this, you will see whorled appearance. Single, they occur either single or they may be multiple. The size typically is variable. It may start from a peanut or it may go up to a size of a huge abdominal mass. So the size is variable. This is also a fibroid uterus, which is rounded, globular, firm in consistency, and cut section shows whorled appearance. You can see this is the whorled appearance due to the muscular fibers. On microscopy, the smooth muscle cell bundles are arranged in the whorled pattern with variable amount of connective tissue. So these are the smooth muscles which are arranged in a whorled appearance, and there is connective tissue in between. Predominance of fibrous tissue is rarely seen. So mainly it is smooth muscle cells. It is the most common tumor, benign tumor of the female, and in 20 to 30% of women of reproductive age group. It never occurs before menarche, and it regresses after menopause, and peak incidence is in the 4th and 5th decades. It is found more commonly in infertile women and in women of low parity, while it is twicely more common in Black women, African American women, and 3 times more likely to get fibroids than Caucasian women. So it is the most common female tumor, occurring mostly in the reproductive age group, and peak incidence is in the 4th and 5th decade in females of in nulliparous females or in low parity, and it's more common in Black African American women. Regarding hereditary factor, it is it runs in the families also. If a mother had a fibroid uterus, her daughter also can have a fibroid uterus. So it is twice more common if a patient has a family history of fibroid uterus. Exact etiology is unknown. Why there is formation of fibroids into the uterine wall? Maybe it is genetic predisposition, or there is prenatal hormone exposure, or if a patient is taking exogenous estrogens, it may cause growth of the seedling fibroids. The risk factors uh, which may contribute towards the formation of a fibroid are African American descent, if a patient is nulliparous, infertile, or if she is obese, because obese patients they have more quantity of fat aromatase, which converts androgens to estrogen, and this estrogen causes growth of the fibroid. Or if the patient has polycystic ovarian syndrome, because in polycystic ovaries there is unopposed estrogen action and it will cause growth of the fibroid. In diabetes and in hypertension also. So these are the risk factors which may contribute towards the development of the fibroid. While pregnancy and smoking decreases the risk of fibroids. The fibroid growth is strongly dependent on the estrogen and progesterone. Higher the concentration of estrogen progesterone receptors in the fibroid. So the fibroid uterus, they have estrogen progesterone receptors in larger amount. So if a body is producing excessive estrogen progesterone, they will bind to these receptors and they will cause excessive growth of the fibroid. Chain arch analogs. These are the gonadotrophin releasing hormone analogs, which reduces the size of fibroid by reducing the estrogen level. So these are the anti-estrogens, which reduces the size of the fibroid. OCPs, oral contraceptive pills, they also increase the size of fibroid because they contain estrogen and progesterone. Obese women, as I already told you, they have higher risk because of high serum estrogen levels because the fat aromatase convert androgens to estrogens. So they will cause excessive growth of the fibroid. Now we can classify the fibroids according to the site of the uterus. So they may occur within the body of the uterus, they may be cervical fibroids, or they may be intraligamentary fibroids. If they are within the body of the uterus, they may be intramural, subserosal, or submucous. As you can see over here, this is the uterus, this is cervix, and this is vagina. These are the fallopian tubes, this is the ovary. So this is the submucosal fibroid, which is projecting into the endometrial cavity. This is the intramural fibroid, which is present in the muscular layer, myometrium. And this is the subserosal fibroid, which is in the outer layer of the uterus. And this is subserosal fibroids. If it gets pedunculated, then it is called pedunculated fibroid. And this is the pedunculated cervical fibroid. So it is arising from the cervix and it becomes pedunculated and it protrudes into the vagina. So this is a pedunculated cervical fibroid. So we classify the fibroids according to the site they are present. Submucosal, subserosal, intramural, pedunculated, intraligamentary if they are present in the broad ligament of the uterus, broad ligament, and they are cervical fibroid if they are present in the region of the cervix. Intramural fibroids, they are within the uterine wall. They are not capsulated, but pseudocapsule formed with the growth. So these are the intramural fibroids. Blood supplies through the nutrient arteries entering through the pseudocapsule. So they have a pseudocapsule. They have not a true capsule, but they have a pseudocapsule and the blood supplies through the nutrient arteries. The subserosal fibers. This is uterus, fallopian tubes. This is ovary. And this is a large subserosal fiber which is arising from the posterior wall of the uterus. So it originates from the outer myometrium and projects outwards from the uterus. Outwards from the uterus, covered with the peritoneum. In the time larger size due to the lack of the surrounding myometrium, so they may become large peduncle. These are mucous fibroids arising from the inner myometrium. They are covered with the endometrium. So they are arising from the endometrium and they are covered with a layer of the endometrium and project into the uterine cavity and they become pedunculated. These are vital fibroids. They are usually less common, 1 to 2%, and arise from the cervix, usually single and confined to the supravaginal portion of the cervix, either the intramural or intraluminal. While the intraligamentary fibroids, they are present with a broad ligament, either in the round ligament or in the ovarian ligament. So the intraligamentary fibroids, they are in the either right ligament or the ovarian ligament, usually in the broad ligament. How the fibroid presents. Maturity, they are asymptomatic when they're small in size and they're discovered incidentally when an ultrasound is done for any other reason. Menorrhagia is the most common symptom and it is usually caused by the submucous fibroids mainly and intramural fibroids because it increases the surface area of the uterine cavity and causes increased blood loss. But the cycle is regular. Sometimes these submucous fibers they get ulcerated and damaged endometrium over the fibroid. It will also lead to excessive bleeding. And they also cause mechanical completion of the venous drainage by the fibroids. So all this lead to excessive bleeding. Intermenstrual bleeding may occur if there is ulcerated submucous fibroid, or postpartum bleeding is caused by the pedunculated submucous fibroid. So the main symptom is menorrhagia, intermenstrual bleeding, or postpartum bleeding. Subfertility is also, and the fibroid may also present with subfertility in 30% of the patients. This may be due to the interference in the implantation or if the fibroid is blocking the tuberosity. Pain is another symptom. It usually starts when complications are caused in the fibroid. Either it may get torsion if it is pedunculated, or it may undergo red degeneration during pregnancy, or if there is sarcomatous degeneration. Urinary symptoms are due to the pressure symptoms. Cervical fibroids cause irritation of the bladder, increased frequency of urine. Larger cervical fibroids, they got impacted in the uterus, pelvis, and they cause urinary retention. So there are two types of urinary symptoms. Either there's increased urinary frequency due to the irritation of the bladder, or if there are larger cervical fibers, they may cause urinary retention. The pressure symptoms, they are caused by the larger fibroids, which cause interference with the venous and lymphatic drainage of the lower limb, causing edema and the varicosities. And pressure on the pelvic ring cause hemorrhoids. So these are the pressure symptoms. And if there are huge fibroids, they may cause abdominal pelvic mass. It will lead to dyspepsia due to the stomach irritation and dyspnea due to the pressure of the lungs. So sometimes we have a fibroid of about a 30-week or 32-week size pregnancy. So if such a huge fibroid, it will cause dyspepsia, it will cause dyspnea and urinary symptoms. So how to examine a patient with fibroid uterus? Whenever you come across a patient with fibroid, then you will start from the general physical examination, abdominal examination, and then you will do gynecological examination. A general physical examination, as the main complaint is menorrhagia, you will look for the signs of anemia. And if she has huge fibroid, she will be also breathless. And if it is having pressure effects, then she will have edema of the lower extremities and viscosity. On abdominal examination, uterus is palpable abdominally after 12 weeks size of the pregnancy. A single fibroid when it is present centrally in the uterine body. It is central in location in the abdominal cavity and has smooth surface. If there are multiple fibroids, then it is an irregular mass which may be shifted to a side. And fibroids, they are firm, non-tender masses unless they undergo any complication, then become tender. On pelvic examination, the steps of pelvic examination are first speculum examination and bimanual examination. On first speculum, when we introduce a cusp speculum inside the vagina, we will visualize the cervix and we will then see if there is any mass protruding from the cervix or arising from the cervix. Or patients with menorrhagia or intermenstrual and postpartum bleeding, we can see the bleeding through the speculum examination. On bimanual examination, if it's a single fibroid, it will be a central mass, firm in consistency and smooth surface. And if it is multiple fibroids, there will be an irregular fan mass which may be shifted towards one side. What are the complications which can occur in this benign tumor? So these are related to the size of the fibroid. If it is subserous fibroid, if it is pedunculated, it can undergo torsion or twist in the pedicle, occludes the blood supply leading to ischemia, presenting with acute pain. And sometimes the sessile subserous fibroids, they may get adherent with the bowel, subserosal fibroids. They may become adherent with the bowel or a mentum, and it develops its own blood supply and gets separated from the uterus, forming parasitic fibroids. Some mucous fibroids which are present in the uterine cavity, if they get pedunculated, they may prolapse the cervix, causing intermenstrual postpartum bleeding, and get infected and ulcerated and may cause uterine inversion also in some cases. Cervical fibroids, if they are large, they may get impacted in the pelvis, causing ureteric obstruction and urinary retention. So these pedunculated fibroids, they may get ulcerated and they may cause intermenstrual bleeding, postpartum bleeding, and these pedunculated subserosal fibroids, they may get detached from here, acquire blood supply from the mentum and bowel, and they become parasitic fibroids. Now, degeneration is another complication of the fibroids. Let's try to the fibroids from the periphery and the central areas relative to the prime of it. So, a rapidly growing tumor easily undergo degeneration. So, there are certain types of degenerations. Hyaline degeneration, it is soft, and on cut section, it is whorl pattern is lost and it becomes cystic in the center. So, this is hyaline degeneration and becomes cystic if there is no whorl pattern. So, in this, there is no whorl pattern. This is hyaline degeneration. Fatty degeneration occurs in the fibroid and it should be differentiated from a uterine lipoma. As you can see over here, this is the fibroid uterus and it has, this is fibroid uterus and this is also fibroid uterus, and it may go fatty degeneration. This is how you would see on histopathology. This is fatty degeneration, fat blood inside the ileum. Red degeneration is a special type of red degeneration which occurs only in pregnancy. Thrombosis of the peripheral blood vessels, while other become disbanded and engulfed in the red blood cells. So it appears red on cut section due to the presence of thrombotic and hemolytic changes. So this degeneration, it occurs only during pregnancy. If there is pregnancy with fibroid, so the degeneration which occurs is red degeneration, and it appears red due to the presence of thrombosis and the hemolytic changes. Engorged red blood cells in the vessels. calcification due to the poor blood supply. So calcification can also occur due to the poor blood supply. Rarely it may undergo sarcomatous degeneration. It occurs in 0.1%. So this is how the degeneration would appear in conception. Infections. We choose subserosal fibroid for infection from the neighboring organ infections like appendicitis, diverticulitis, if biosalpingitis, the intramural fibroids after abortion and during percurium, submucosal fibroids after ulceration. So infection can occur after miscarriage or after delivery, or if submucosal fibroid undergoes ulceration, it may get infected. Hematological complications include anemia. There will be anemia and increased erythropoietin production. It will lead to polycythemia. So these are the two hematological complications. Now, how we can diagnose fibroids? We will start from the history, examination. An examination you can find on abdomen examination. If it is a huge fibroid, you can palpate firm globular mass in the lower abdomen. And if it is a pelvic mass, then you can detect it on bimanual examination. Then comes the investigations. Investigations include do it with hysteroscopy or laparoscopy. And other investigations include hysterosalpingography and modern imaging techniques and CBC, complete blood counts. On ultrasonography, the fibroid appears as an echogenic mass in the uterine wall that causes nodular distortion of the uterine outline. If the mucus or a small intramural fibroid, they will distort the endometrial lining, central endometrial aqueous, they will be disturbed. Fibers with Hyaline degeneration, they have anechoic areas within the fibroid. And fibers with cystic degeneration, which give no small appearance. So this is how you will dead fibroid uterus on ultrasound. You can see this is the central endometrial lining. This is the uterine wall, and this is the small fiber. One is this, and the other is this. So these are the small echogenic masses in the uterine wall. This is the uterine wall, and this is the endometrial lining. Hysteroscopy and curettage. Hysteroscopy provides a direct view of uterine cavity and is indicated during abnormal uterine bleeding. So small submucous fibroids they are missed during ultrasound. So we can do hysterosalpingography. This is how we do introduce the hysterosalpingography. Fibroids. So this is the view of the hysteroscope. Through a hysteroscope, this is the inside of the uterine cavity. This is the endometrium, and this is the fibroid. This globular mass rising from the endometrium is the submucous fibroid. Sometimes there is heavy menstrual bleeding, and there may be a coexisting pathology, endometrial pathology. So for that, we have to do endometrial curettage also to rule out any hyperplasia or any other cause of menorrhagia. So this is how we do a curettage with an curate. This is a uterine curate. Laparoscopy is indicated when the mass cannot be differentiated on the ultrasound, or it is associated with infertility or chronic health. Then we do a histology. Then we do a laparoscope. So this is a laparoscope which is introduced through the infraumbilical vein, and this is the uterus. And this is the fiber, which is the subcutaneous fiber. This is cervix, vagina, and this is the fiber, which is subserosal fiber. Hysterosalpingography is also indicated if a patient is infertile and there is a submucous fibroid. So as to localize the site of the fibroid, we have to do hysterosalpingography. This shows this is how the dye is injected. This is the uterine body. These are the tubes. And this is the filling defect which shows submucous fibroids. So this is the normal endometrial cavity. But this is the filling defect which is occupied by the submucous fibroids. Here again, dye is injected to the cervix. Cervix. This is the uterine wall. And here is the filling defect. So the whole of the uterine cavity is not outlined. So this filling defect may be a submucous fibroid. The modern imaging techniques include CT and MRI. They are too expensive, so but they can be used if there is any suspicion in the mass. The deep blood count is offered because to detect menorrhagia and the type of anemia, to detect anemia, type of anemia, and also polycythemia can also be diagnosed. Now, how you will treat? How you will manage a patient with fibroid? It can be a conservative, medical, or surgical treatment. Conservative, what do you think when it will be conservative? Obviously, when the fibroid is small, asymptomatic, nothing, no symptoms, so you can manage, and it is an incidental finding, then you can manage conservatively. And what you do in conservative management, you will only observe and follow with ultrasound and symptomatology. You have done an ultrasound, it shows an asymptomatic fibroid, you will do repeat ultrasound after 3 months to see whether the size is increasing or decreasing or the same. So we have to do follow up in this regard. Usually asymptomatic fibroids, they are less than 5 week size. And if the patient is above 40, she's approaching menopause, and they can be left as such because after menopause they will regress. And removal is only indicated if it becomes increasing in size, it becomes symptomatic, then we have to do treatment. Now, medical treatment. Ideal drug which causes complete regression of the fibroid is GnRH inhibitors. It has shown promising results. They are available in the form of monthly depot injections, which are given intramuscularly in the. They are available in the monthly depot injections. They are available in the form of nasal sprays, and they are prescribed for every 3 months. They improve symptoms of menorrhagia in 80% of cases, and in 50% of cases, they reduce the size of the fibroid. But the disadvantage is they are very expensive, cannot be afforded by all the patients, and they cause hypoestrogenic state, that is pseudomenopause, if they are used for a longer term. And you have to add hormonal therapy, HRT, hormone replacement therapy to the patient. So yeah, they are usually given for a period of short time, usually 3 to 6 months, and so as to decrease the size of the fibroid and to reduce the vascularity also before surgery. Long-term use only allowed when the patient is unfit for surgery, and if she is obese, there are extensive radiations, she had previous surgeries, or she is approaching menopause. The other medical treatment options include OCPs, combined or contraceptive pills. They have estrogen content, it may increase the size of the tumor. Lever nodules intrauterine system can be inserted if it is not a submucous fibroid, because if it is a submucous fibroid, it will distort the uterine cavity, and this myelina, it can be expelled out. Ulipristal acetate, it is a selective progesterone receptor modulator. It is an oral medication. It is a trial drug. Still need more trials. It reduces the size of fibroid prior to surgery. So this is medical treatment. So the main focus is on the GnRH analogs, which will reduce the size and vascularity of the fibroid prior to surgery if it is a larger fibroid. Now, surgical treatment. Surgical treatment is in the form of conservative surgery or radical surgery. So conservative surgery is myomectomy, only we remove the fibroids, and hysterectomy, in which we remove whole of the uterus along with the fibroid. So myomectomy is an operation of choice when the patient wants to conserve a uterus. If the patient is symptomatic, she is young, she is infertile, and fibroid is the only pathology contributing towards her infertility, or she is wishing to have more children, or she has a history of recurrent miscarriages and she had a fibroid uterus, then we will do myomectomy. Or the patient has fibroid but she wants to conserve her uterus. So these are the indications of myomectomy. Myomectomy can be done by various routes. It can be done by a vaginal route or abdominal, and it can be done by endoscopic surgery. So if it is a submucous, small submucous fiber less than 3 centimeters, then it can be removed via hysteroscope. And if it is a large intramural or substotal fiber, it can be removed by laparoscopy. So endoscopy includes both laparoscopy and hysteroscopy. So abdominal myomectomy is performed when it is a big fibroid, and vaginal myomectomy if it is a pedunculated submucous fibroid protruding through the cervix. It is removed vaginally by ligation its pedicle with water. What are the disadvantages of myomectomy? During myomectomy, excessive bleeding can occur, and patient may lose blood, and she may need blood transfusion. And sometimes it is uncontrollable, and we have to resort to hysterectomy. So whenever we do myomectomy, we take consent, myomectomy plus hysterectomy, because sometimes in dire situations we have to remove the uterus due to excessive bleeding. She may have early postoperative complications like pyrexia, paralytic IBS, that's prolonged postoperative recovery, delayed complications, intraperitoneal adhesions causing infertility and intestinal obstruction. And recurrence may occur in 15% of cases. So if you have done myomectomy once, you may leave the seedling fibers inside which are not visible, and they will grow later in a larger fibroid. So recurrence in 15% of cases. Hysterectomy is the removal of the uterus. The whole of the uterus along with cervix is removed. It is usually through abdomen. Advantage is it has low postoperative morbidity and there is no risk of recurrence. This is the hysterectomy specimen. This is whole of the uterus, this is cervix, and these are the tubes with it. And this is the huge fibroid which is present in the fundus. So this is a hysterectomized specimen of uterus. So hysterectomy is indicated if the patient is more than 40 years, completed her families, she has multiple fibroids, and she had severe symptoms. This is a radiological technique performed by the interventional radiologist, uterine artery embolization. It is minimally invasive technique. It avoids general anesthesia and surgery. It reduces the blood supply of fibroid. It results in reduction in size by 50%, and further growth of the fibroid is reduced. Reduce the menstrual blood loss by 90%, and friction symptoms are also reduced in 40-70% at the end of the 3 months. So these are the advantages of uterine artery embolization. So this is how we perform a uterine artery embolization. What we do, uh, through the femoral artery, we pass a catheter. Through the catheter, we pass the polyvinyl gel particles. So this syringe injects the polyvinyl gel particles. These are the gel particles, which will go via the femoral artery to the common iliac, external iliac, common iliac, and then it will go to the uterine artery. And here it will block the blood supply of the uterine artery, which is entering, giving branches to the fibroids. So when it will block the blood supply here, it will block the blood supply and it will reduce the size of the fibroid. So this is how the uterine artery embolization works. Reduce the size, reduce the vascularity, and reduce the symptoms. Again, this is the closer view. Polyvinyl gel particles. This is the catheter, and these gel particles, they will enter the uterine artery, and they will enter these nutrient arteries, and they will block these arteries and block the blood supply to this fibroid. So it will shrink, undergo necrosis, size is reduced, vasculitis is reduced, and the symptoms are reduced. What are the contraindications in which patients we cannot do? If there is subserosal and pedunculated fibroid, the necrosis may lead to the fall of the fibroid into the bottom of the vagina. And if it's a very big submucous fibroid, it is not cured, it does not help in fertile women, or that may increase the problem. So the technique I've already told you how it is done. The results. What are the results of this? Vascularity in the size is reduced by 40% at 6 weeks and 75% at the end of 1 year after uterine artery embolization. Symptoms are relieved in 70% of women. The main symptoms is menorrhagia. Procedure is equivalent to myomectomy in alleviating menorrhagia and pressure symptoms. And one third of the women, they further require medical, radiological, or surgical intervention within 5 years. So this is the drawback, that the patient may require further intervention within 5 years, almost one third of the patients. What are the complications? Patient may undergo fever. Patient may have infection, urinary discharge and bleeding, unbearable ischemic pain, pulmonary embolism. He may have, due to this radiological exposure, premature organ failure, or if there is occlusion of the ovarian vessels, she may have ovarian failure. Fertility is reduced due to lesions, and failure due to incomplete coagulation caused by the spasm or tragedy of the blood vessels. So these are the complications of the uterine artery embolization. Advantages over surgery is no surgery is required, no intraoperative bleeding, shorter hospital stay, no abdominal adhesions, and 75 to 80% of women suffering from menorrhagia, they are satisfied. The other techniques, the new techniques, which can be used as a management option. These are MRI guided percutaneous laser ablation using high intensity focused ultrasound, HIFU, has been recently attempted. The results are awaited. So it is being done even here in Lahore, but the results are awaited whether there is recurrence after that or what are the complications which can occur after that. The other is laparoscopic myolysis. The fibroid is lysed. It is an optimal surgery in multiparous women by using laser, anti-ag laser or cryoprobe or diathermy to calculate the subserosal fibroid. The contraindications are similar to uterine artery embolization. Phrygian arch analogs, they can be given preoperatively to shrink the size of the larger fibroids. The fibroid enucleation will be easy to perform myomectomy and hysterectomy, thus reducing the ureteric and bladder injury. So these are the newer techniques which can be employed in cases of larger fibroids. Fibroid uterus can be have a differential diagnosis with adenomyosis or ovarian tumors because in both conditions there is a massive abdomen. Adenomyosis is then also called adenomyoma. In this condition, there is presence of endometrial tissue inside the myometrium. So it is a disease of multiparous women. Menorrhagia is associated with severe dysmenorrhea. So if a patient has massive abdomen, if she is multiparous and she has severe menorrhagia with dysmenorrhea, and uterus is uniformly enlarged and tender on touch, then you can think of adenomyosis also. And ultrasound thickened myometrium with Swiss cheese appearance can be seen on ultrasound. And on cut section, you can see lack of world appearance on ultrasound. So this is how you differentiate the fibroid with adenomyosis. And ovarian tumors, they are confused with pedunculated subserosal fibroids. Menorrhagia is usually absent in these subserosal fibroids. Mass feels separate from the uterus while fibroids have limited mobility. So ultrasound may be helpful, but diagnosis is not confirmed until laparoscopy or laparoscopy is performed. So this is the DD of fibroid. Now we will conclude our talk. There are certain key points to remember. Fibroids are common in 20% of women over 30 years of age. So it is in the reproductive age group. Estrogen-dependent tumor, it regresses after menopause. So after menopause, there is a hypoestrogenism and the tumor will start progressing. It is mostly asymptomatic. Only symptomatic should be treated. And hysteroscopic technique, submucous fibroids, is successful and to avoid major surgery. Mechanisms whereby fibroids affect fertility is unclear. Only if it is located at the tubal ostium and if it is blocking the tubal ostium, then they may be a cause of infertility. But if they are subserosal or if they're intramural and they're not distorting the uterine cavity and she has infertility, then the mechanism is unclear why there is infertility, if there is no other reason found. So these are the take-home messages. So I hope you understand about the fibroid. It is myoma or leiomyoma. It has been classified according to the site where it occurs, and it can be diagnosed by history. In history, what you will find, there will be history of menorrhagia, having most of bleeding, intermittent bleeding, postpartum bleeding. She may have anemia, she may have breathlessness, she may have dyspepsia due to the large tumors. And on examination, during physical examination, you will find signs of anemia and polycythemia, and she will be dyspneic if she will have increased respiratory rate if she has a huge tumor. And on pelvic examination, you will find pelvic abdominal mass, which is firm in consistency if it is a single fibroid, it is rounded um, and mobile. And if these are multiple fibers, then it is a multinodular irregular firm mass, which is usually non-tender. If it is a petangulated mucous fibroid or cervical fibroid, you can see it can be protruding from the cervix. The investigations which can be done include ultrasonography, hysteroscopy, hysterosalpinography, MRI, CT if it is a huge mass and you cannot diagnose whether it is fibroid or some other mass. Then we can take the help of MRI and CT scan. Hysterosalpinography can be used in cases of submucous fibroid if the patient has infertility also. So we can check both. We can see the tubes and we can look at the site of the fibroid also. So this is how we will diagnose with the help of investigations. And regarding treatment, it is conservative. If it is large, it is a small asymptomatic fibroid and the patient is about 40 years, it is approaching menopause, because after menopause the size will start reduce. So during conservative management, we will only observe and we will be planning after 2 to 3 months to see the size of the fibroid. And then surgery and medical treatment. Medical treatment, the promising results are offered by DNRH analogs, which will reduce the size and the vascularity, but they cannot be given for a longer term because they cause a hypoestrogenism, that is hot flushes, night sweats. The patient starts having menopausal symptoms if it is used for a longer period, 6 months or more. So they are given for a period of short time, 3 to 6 months. Other medical treatment options include OCPs, but OCPs they contain estrogen, they may increase the size of it. They will control the menorrhagia, but later they may increase the size of the fibroid. Then Mirena, which is liver nodules in intrauterine system, it can reduce the size of the fibroid menorrhagia also, but if it is a submucous fibroid and it is distorting the cavity, endometrial cavity, it can be expelled out. Then there is uliprostol, which is selective progesterone receptor modulator. It is an oral drug, but still a trial drug. It can reduce the size of the fibroid before surgery. So these are the medical options. While surgery, it may be conservative or definitive radical surgery. Conservative is myomectomy and radical surgery is hysterectomy. In myomectomy, we will only remove the fibroid. It can be done abdominal or vaginal route or by endoscopy, both by laparoscopy and hysteroscopy. Hysterectomy is done in those women in which they are more than 40 years, they have severe symptoms, they have completed their family, and there are multiple fibroids. So hysterectomy is the definitive treatment. Advantage is that the patient will not have recurrence. While after myomectomy, she may have recurrence of the fibroids. So there's another new technique, uterine artery embolization, which is a minimal invasive technique done by intervention radiologist. It is not available everywhere, but it can be done in Royal General Hospital where we have intervention radiologists. So in this technique, we reduce polyvinyl gel particles through a catheter into the femoral vein, and through this femoral artery, these polyvinyl gel particles, they are uh, injected, they will go to the uterine artery, block the entrance artery, and it will cause necrosis, reduce the size of the fibroid, and also decreases the vascularity of the fibroid. The uterine artery embolization, it has chromosome results. But 1/3 of women after uterine artery embolization, they still require further treatment, either medical or surgical. So the DT of fibroid uterus is adenomyosis and ovarian tumors. So you must know how to differential diagnosis with fibroid uterus. So this is all about myoma, earlier myoma. I hope you can define, you can describe the fibroid, you can um, diagnose it with the help of examination and investigation and history examination and investigations, and you can manage the patient with the help of different management options. So if you have any questions, thank you very much. If you have any questions, you can ask.